Marshal?
Air Marshal. Yes, sir.
I can't hear, there is a lot of echo.
Can you hear
Okay,
us?
I believe I am audible and I think my slides are visible. Thank you very much. I must first apologize for not being there in present.
I'll request you to start the session, sir.
Is there anything? Should I continue or should I start a bit later?
You are audible, sir. I just increase the volume.
And my slides are visible.
Yes, sir.
So I proceed. In the beginning, I must offer my apologies for not being there in person due to certain commitments that had come up urgently here in my present place of occupation. So my apologies to everyone. I had planned to be there amongst all of you and improve my knowledge and learnings and met my old friends. However, that was not possible. I thank the organizers, I thank Dr. Johar, I thank the President of Academy of Hospital Administration, Dr. Yashpal Sharma. I thank Bhubaneswar All India Institute of Medical Sciences, Department of Hospital Administration, for giving me this opportunity to share some of my experiences, some of my thoughts on a topic which is very close to me and which is very, very dear to me. My regards to all, to the patron, General S.K. Biswas, to General Manindra Srivastava, to Dr. A.K. Gupta, to Dr. D.K. Sharma, who have been my teachers and mentors all through my career in the armed forces and as well as in the discipline of hospital administration. I also have paid my regards to my seniors like Dr. R.K. Chaturvedi, who has shown me the light and path how to deal with administrative challenges, and my regards to all my colleagues, my friends, and all the students. And my compliments to the organizer for organizing such a beautiful conference, and which should be hopefully a game changer for hospital administrators to take back lessons learned and apply them practically. But I have certain disclaimers and declarations to make. The views that I express here are my own views, and those who have similar views probably share similar thoughts or possibly have read the same material. Those who have different views are welcome to share them, and no copyrights are sought. Content of this presentation can be used by students and viewers alike, but please, sometimes when I go back, I become a plagiarizer of my own presentation, so please don't let that happen in the future. My presentation is going to be brief, but it's going to be hopefully relevant because I'm going to talk about quality program, the costs versus benefits. I wish to say with some amount of caution here that whatever I'm going to state here are concepts that have been taken up from various literature, but I have compiled them together. I did a meta-analysis of almost about 60 papers on cost versus benefits of quality programs and accreditation systems across the globe. I am afraid I would not like to share those findings because those findings left me more confused than they gave me any path to discuss about this topic. Whatever I am going to state here is relevant to all hospitals at appropriate levels, whether it is primary care hospitals or whether it is tertiary care hospitals or whether it is a primary health center or community hospital. But you have to adopt and adapt from my presentation. I am not going to tell you anything which is rocket science. I am going to tell you something which is very, very simple and which is simple to understand and maybe simple to decipher and implement in the long run. So we'll begin first with quality program. Now let us understand what is a quality program. To understand that, we must understand what we want to think quality is all about. Now quality is very difficult to be defined in a precise manner, especially when it comes to healthcare, because it has got both tangible and intangible aspects. It deals with both technical aspects of care, it deals with the behavioral aspects of care. But let us simply define it that quality is degree of adherence to pre-established norms or standards. quality programs are nothing but those programs which adhere to these established or evidence-based standards, protocols and procedures. And main focus of any quality program, all of you know, are on structure, processes and outcomes. I will not elaborate on this right now. Now cost. Cost is slightly more easy to define, but it is less easily understood. Because cost also has tangible and intangible benefits, or rather tangible and intangible components. The tangible components are the direct and the indirect, or the fixed and the variable costs, but the intangible costs are those which cannot be economically measured as per the money measurement concept. So what is a cost? A cost is a sacrifice. Now, I could not attend the program, so I have to sacrifice the program at the cost of my work here. Some of you sacrifice to work at the cost of attending the program there. So, cost is a sacrifice which is made in the present or promised to be made in the future to acquire certain benefits now or at a future point of time. When you convert these costs into money, they become financial costs. Otherwise, they remain a sacrifice. Now, does quality cost? I'll be very clear about it. Yes, quality costs. It costs many things. We'll go one by one. There are structure-related costs. That means infrastructure will cost you, and quality will cost you to make more investments in your infrastructure for fire safety, for operation theatres, for designing of services, for having certain component services which ensure that continuity of care continues to exist in that healthcare setup. So it costs. Infrastructure costs will be there. Human resources, yes. To provide quality care, you must have adequate number of professional, credentialed and privileged staff, both nurses, doctors as well as paramedical staff. Also, you will like to have quality teams, you like to have infection control teams, safety teams, risk management teams, CPR teams. That means so much of expertise have to be there for which you will have to spend money. Yes, you need the requisite materials and medicines. You will need technology, you will need space and you will need information systems. All of these are structure related costs which have to be incurred if you want to improve your quality. What are the process related costs? Well, you have to have quality planning processes where all the teams will come, meet, prepare the quality manual, prepare the infection control manual. So this is a cost of time. This requires efforts. Both of them cost. You have to sit down and make risk management, your risk assessment programs. You have to train people. Train on certain common attributes like biomedical waste management, on hospital infection control standard precaution practices, on hand hygiene practices, and you have to retrain once you feel that training has become obsolete, some new protocols have come up, so you can retrain. Then your inspection and audits, your prescription audits, your nursing audits, your clinical audits, all of them will require time, effort, energy. These are also costs. And of course, the cost of monitoring and evaluation of all your processes. Finally, outcome related costs. If they are redos, they will cost. If they are readmissions, that will cost. If you are rescheduling, it will cost. If patients are dissatisfied, employees are dissatisfied, they will cost. If there are adverse events and incidents, they have a cost. And when you take corrective and preventive actions for all these outcome related incidences, they also cost. So there are outcome related costs. Now if I have to tell you the cost of quality, and if you go through what is given in the literature, you will get confused. I am not going to read this definition, but I am going to divide this definition into more easy and understandable concepts. The concept says the cost of quality has got two components. One is cost of good quality, which is cost of conformance to standards, to protocols, to procedures, or to the best practices as per current knowledge. And cost of poor quality is non-conformance to those best practices or those standards or protocols. So the cost of quality is a combination of good as well as poor quality. Now, what are the costs of good quality? They are the costs which prevents from adverse events from happening. So these are costs which are incurred in advance to prevent or avoid quality problems. To prevent and avoid fire and fire related hazards, you have got fire safety equipment, fire safety training, and mock drills. So all this you are taking action to prevent a fire. This is one example of prevention cost. You do preventive maintenance, that is to prevent an equipment failure, to prevent a defibrillator from discharging at the time you really need it. This is what is prevention cost. You are making checklists to prevent any side effects or any surgical safety or any incidents happening which are adverse to patient care. This is one of the cost of good quality. Whatever preventive measures you take and you put in efforts, money and time in preventing adverse events, this is cost of good quality. Another cost of good quality is appraisal costs. That means those costs which you incur for measuring and monitoring activities related to quality, which means your calibrations, your quality control mechanisms, your own internal audits, all these put together, they are appraisal costs. So whatever audits that you do, whatever appraisal, monitoring, evaluation that you do, whatever cost you put into it, they will help you to improve the systems, they will help you to prevent an incident from happening. These are all costs that you incur to prevent adverse events and to improve quality of care. So these two costs are known as cost of good quality. Now there is cost of poor quality. The cost of poor quality are internal failure costs. That means they are referred to those remedy defects that are discovered before or during the delivery of service, like instrument downtime, repairs of equipment, data entry errors, missing specimens, redos, wrong site surgery, various sentinel events, medication errors, and the second victim, the person who has committed that error. These are internal failure costs. When these failure costs reach out to the environment, they become external failure costs. That means all the customer complaints, all your misdiagnoses and misinterpretations, all the misperceptions get communicated to your clientele, and therefore those costs can result in violence, can result in various adverse events that should not take place. And of course, finally, they can result in litigations and lawsuits. So these are the costs of poor quality. Now, internal and external failure costs have also got two components. One is the hard costs which are obvious, which are very easy to calculate, which means supposing you have got a non-conforming event that has happened, that a fire safety event has happened. Now you are taking corrective measures to ensure that the fire safety incident is not repeated. They are obvious costs. You can calculate those costs. Or for example, you have got reagents and supplies which are wasted, or repair of failed equipment. All these costs can be easily calculated. These are the hard costs. The soft costs, they are very less obvious and therefore very, very difficult to quantify. They still negatively impact the financial organization, and these relate to low employee morale or the reputation damage that occurs to a healthcare organization because of these failures. Let's see, what are these soft costs? We do not know how many potential customers we lose, how many potential clientele we lose due to damaged reputation. Also, we do not know the stress and low morale that an error may cause for employees, could lead to an increase in burnout, could lead to poor focus leading to more errors, could lead to work-related illnesses or higher turnover rate, more absenteeism. All these are soft costs. So these costs may not be so easy to determine. So here are the total quality costs which you can see. That is prevention and appraisal, if you do that, if you incur cost in prevention and appraisal, they become the cost of good quality. And if you have got internal failure and external failure, you are going to address mechanisms and put in mechanism to address internal and external failure, they become cost of poor quality. Okay, so these are all costs. When the patient comes back and says, I want my money back, I did not get my money's worth. So, all these are costs of quality. This is total quality cost. So, what are the benefits? So, if you are incurring costs, there have to be some benefit. Benefit of cost of good quality, that is preventive and appraisal costs, are these certain tangible benefits, certain intangible benefits. The tangible benefits are all for all to see, because if the quality of care is good, if we have put in mechanism in place to provide good quality care and safe patient care, you will have less average length of stay, you have greater bed turnover and occupancy, more patients will be served on same number of beds, there will be reduced incidences of errors, complications and adverse events, there will be reduced healthcare associated infection rates, there will be lesser redos, lesser rescheduling appointments and surgeries, there will be lesser number of readmissions to critical units for same ailment, there will be reduced mortality and morbidity related to that healthcare organization, there will be increasing clientele will be coming to your organization because of your spoken reputation, greater revenues will accrue, there will be lesser employee turnover and absenteeism, there will be reduced failure of equipment, lower inventory carrying costs, less wastages, lesser incidences of violence, and lower or nil litigation costs. Then there are intangible benefits. Higher patient satisfaction, better patient experience and patient reported outcome measures, better public image, better employee satisfaction and improved productivity. So you have happy patients, happy visitors, happy families and happy staff and a happy hospital. These are the intangible benefits. Now, we all know that to get these benefits, we have to invest in quality, in good quality, so that we do not have to bear the cost of poor quality. So we have to invest money in good quality. How much money to invest? Okay, now this is something which nobody can say. All the studies that I have read so far, they say yes, higher costs, investments in quality programs leads to better quality of care, lesser patient safety incidences. Lesser investment in quality will lead to lesser quality. Both things can happen. Sometimes both are directly proportional. In some studies they say there is no relationship. So how to arrive what cost should we invest at what level of care? Now this is something which I picked out from the inventory carrying cost. All I have done is I have replaced everything from the EOT model to the balance cost to optimize benefits. If you see, you have got the x-axis, you have got quality, on the y-axis you have got cost, you have got low component and high components. Same thing, low cost for quality, low quality and high quality. Now once you put this diagram, you will understand that there are certain costs. If you put in low costs in implementing quality, the chances are that you are going to get low returns on quality. But when you continue to increase the cost of implementing quality, you are getting higher and higher quality. If you do not put in costs, if you do not invest in quality, the cost of error rectification keeps on becoming higher and higher and higher. If you see from the right hand side where the cost of error rectification is becoming higher and higher, as and when your quality levels are becoming lower and lower. So when you follow this, the second red color, small pink color line, you will find this is the cost of error rectification. Where the cost of, this is the total cost which takes into consideration both cost of implementing quality and cost of error rectification. So where these two cross, the cost of implementing quality and cost of error rectification, that is where the cost is lowest, and that means you can balance your cost to optimize your benefits. This is the traditional way of doing cost benefit analysis for optimizing your benefits. Now this is an emerging model. This model says that quality of conformance has to be 100%. The quality of conformance should be 100%. Here, greater emphasis is laid on cost of appraisal and cost of prevention, because these are cost of good quality. And we are assuming that over a period of time, this cost of appraisal and prevention will become a fixed cost. It will be relatively fixed over a period of time. This model is not encouraging trade-offs. Okay, we have a balance mechanism where the rectification, cost of implementation of quality will come and meet and will optimize. This is not saying any trade-offs. This says that total cost is not to be minimized at less than 100% conformance. This model states that once you reach a level of quality of conformance of 100% conformance to lay down norms and your criteria and standards, the total quality cost will come down to minimum. Means quality will need cost in the beginning, but subsequently when you implement quality and conform to standards, gradually the total quality cost will come down to minimum. So this is the emerging model of cost. We should be focusing on this model. Okay, so to get desired benefits, we must first identify non-conforming events. We can identify by reporting mechanism in place once an event has occurred, or also we can identify by being proactive. So if you identify when a non-conforming event has occurred, do a root cause analysis. And if you take up a proactive risk management, then you have to do a failure mode effective analysis. Both these cases will lead you to what are the possible causes, so you can take the requisite corrective and preventive actions. Now, capturing the cost of poor quality with each non-conforming event or near miss allows the healthcare organization to quantify the financial benefit of its corrective actions and other quality improvement activities. And all poor quality and rework, redos, rescheduling, they create unnecessary financial losses, and if you assign a monetary value to that loss, to that waste, it will provide the necessary motivation to all the employees to work together to eliminate such poor quality costs. What steps the leaders can take? Well, the leaders can support the implementation of a system to capture the cost of poor quality data that estimates hard and soft failure costs. All you need to do is to have a simple, small, Excel-based cost of poor quality capture system, and invest in a software solution to streamline this entire process of cost of poor quality electronically. The second they must take is to build a culture of employee empowerment, trust and safety. Once you build a culture of employee empowerment and trust, employee feels safe to report non-conforming events in order that we can take corrective and preventive action against these events. Also, the next step is you must create an engaged workforce. You see, engaged workforce will be able to be more proactive in their approach, and will be able to identify the errors before they occur, and will be able to address them and reduce the cost of poor quality. And lastly, we must invest the resources necessary to succeed. We must recognize that to effectively run any quality program, money will be required, resources will be required, but I can assure you that there will be a return on your investment. With this, I thank everybody to have given me this opportunity to present my concepts, my ideas, and share whatever I could with all of you. Thank you very much. Jai Hind.
Thank you very much, sir. It was excellent presentation, And we have all enjoyed, but we have missed you here in the conference. You talked in detail.
Dr. Yashpal, I can't hear you. I can hear you with lot of echo.
Then I'll request you, ask a few questions. Let's say 2 questions. Since he's on virtual mode, and if there are any questions, then ask them. Anyone? No questions. So thank you very much. Detailed performance. Thank you very much. We really appreciate it.
Thank you for giving me this opportunity. Thank you very much, all of you. Thank you very much.
Next speaker is Dr. Quality Manager and of this field.
Very good afternoon, and thank you very much, organizers, for giving me this great opportunity to speak after my mentor, Dr. Pawan Kapoor. And I bring greetings from Christian Medical College, Vellore, and the Consortium of Accredited Healthcare Organizations in India, the CAHO. So my talk is going to be on building the culture of safety. It's not easy to talk after Dr. Pawan Kapoor, but let me try and do some justice. So, it's not moving. Let me begin. So this is the normal statement we hear, the culture, the way we do things around here. This is exactly what I heard when I joined Christian Medical College in 2007. We've been functioning for 100 years. This is the way we function, and this is exactly what we do. So that's a general statement that all of us hear. When it is one person's attitude, it is an opinion. When it's everyone's attitude, it is culture. So the culture is everybody's attitude. So let's move on to the culture in the context that we are talking in our country. Is this a very uncommon scene? I think it's very, very common in our country. Practically you see on the road on a day-to-day basis. So this is the safety culture in India. So we are now going to be talking about the safety culture. How do we build the culture of safety in our hospitals with the culture of safety in our country at this level? Healthcare and safety, all of us know. The odds of dying in a plane crash versus in a car accident to medical error. It's 1 in 300. In our country, again, we hide behind data. We don't have any data to talk about the numbers in our country. These are some of the estimates. WHO talks about 1 in 10 patients in developed countries. Imagine the state in a low and middle income country like India. AHRQ reports 25.1 per 100 admissions in US. Again, we just cannot substantiate anything in our country. So that is where we are. We get very scared when we fly in an aircraft or when we want to go to a nuclear power plant because we think that's unsafe. But healthcare is actually compared to bungee jumping. You are safer if you climb on top of a cliff, connect yourself and jump from the top of the cliff rather than getting yourself admitted as a patient in a hospital. So the hazard that is related to admission in healthcare is actually under the hazardous industries category. Failures in healthcare delivery, improper hand hygiene because of which you have acquired infections, non-adherence to PPE usage, medication administration errors, patient identification errors, surgery on wrong side retained objects, fire in our setting, wrong gas connected. Are these something new to us? I'm sure all of us hear about it on a day-to-day basis. It's very, very rampant. Now I want to talk about this beautiful lady, Sri Devi. What comes to your mind when you look at this beautiful lady? Young hospital administrators here. Wonderful. This is the first time I'm hearing this. Everybody, instantaneously talks about the 27 plastic surgeries she underwent. But what as a healthcare professional should come to your mind is the incident of her mother. Her mother, Rajeshwari Ayyappan, was operated in one of the leading centers in the US, Sloan Kettering in Manhattan, and she was operated on the wrong side of the brain in 1996. So that's there in US. Imagine the situation here. Fire at AMRI hospital kills 92 people. Have we learnt out of that? During COVID, we have had more than 27 fires in our hospitals. Power outage at Puducherry kills 3 dialysis patients. How can a power outage kill 3 dialysis patients? Let me tell you my experience. I had gone for an assessment to a hospital and into the dialysis setting. And I asked them, in case of an emergency in this setting, let's assume there's an earthquake or a fire, what are you going to do? Busy dialysis setting, 14 patients connected to the dialysis machines. No nephrologist on site, all technologists standing there. Brilliant children there. And I asked them, what are you going to do? They had nothing. They just said, we will call number 300. Yes, call number 300. Number 300 came with fire extinguishers. Immediate response. What are they going to do? Try to put off the fire. Now I said, smoke is spreading. What are you going to do? They were clueless. And one individual told me, we'll wait for the blood to go back. My dear friends, this is the problem. These are ambulant patients. It's a matter of just clamping them, making them sit up, and making them move out of the dialysis setting. Nobody is aware of this in our setup. Ask the surgeon, ask the anesthetist, what are you going to do? Midpoint surgery, nobody knows. This is the problem. So what's happening is we are not learning out of our mistakes. Look at this, doctors operating on wrong leg of a 24-year-old, 15 hospitalized due to wrong drug given before sterilization, 2 stuck in a MRI machine. Even after that, we've had 8 episodes of actually people getting stuck in MRI machines. Have we learnt out of it? Certainly no. And that's probably why every single day you probably hear Arnab Goswami shouting at the top of his voice, India wants to know from all you healthcare professionals. My grandfather was a doctor, and the best of the produce in the village used to come to our house. My husband heads neurosurgery. I don't get any best produce coming in. At least he comes home safe. My son is getting trained. Already twice he's got beaten up. So that's the situation in our setting today. It's extremely difficult because of the challenges we face in our hospitals. I don't know about the government setting, but running a private setup is extremely difficult. What are the challenges? We know the medical negligence, patient safety, litigation issues, increasing expectations of patients. They also have Google. They Google search and come and tell you this is what I want. Healthcare expenditure is on the rise. Lack of skilled manpower, staff attrition, inability of an organization to sustain, lack of risk management, and the culture of safety in our organizations. So it's all about sustainability, and that's the conference theme as well. It is the capacity of organizations, of hospitals, to be able to withstand these challenges and variations over the time through the process of continuous improvement. Are we taking steps towards that? And what should we do? Safety culture, let me come to the definition, is organizations' shared perceptions. It is the belief of the organization, the value and attitude that combine to create commitment to safety and an effort to minimize harm. It is not one individual, but everybody working in that hospital or organization coming together with a shared vision of safety, patient safety, quality, and that's exactly what we talk about. In simple terms, safety culture is the combination of attitude and behavior towards patient safety that are conveyed when you're walking into the facility. When I get into a hospital, certainly I will know if this hospital is committed to patient safety or not by actually looking at the staff, by interviewing them, by talking to them. One sentence will tell you whether this hospital is committed to safety or not. Who are the early adopters of this culture of safety? High reliability organizations. When we talk about HRO, the most complex one is the airlines, nuclear power plants, and all of these, oil and gas industry, where you cannot have a mistake. You cannot send a rocket to space if you know that there's going to be a problem. It's zero error that is expected. So those are all the high reliability organizations, and they depend a lot on technology. And healthcare is actually labor intensive. For every single patient, you know the number of staff who are actually interacting with these patients. So for healthcare to reach high reliability, it is actually a dream. So these are the different levels of safety culture. Now you have to rate yourself as to where you stand in your organization. Is it pathological? No systems at all in place. You can do anything. Patients are like guinea pigs. You can do anything what you want and walk around. Reactive. Systems are piecemeal. There is a small problem, you react to it, it's like a, immediate action. That's it, and everybody is forgotten and moved on. Calculative. You take systematic approach per event. Still, you are not bothered about the umpteen number of incidents that are happening in other areas. Proactive. You look at one incident, then you probably take measures across the hospital. But after some point, it's actually incident-driven. But where we need to go is the generative aspect, where meaningful safety culture central to the mission and vision of your organization. This is exactly what the Institute of Nuclear Power Operations defines safety culture characteristics that are adaptable to the healthcare environment. So we can learn lots from the other industries, but we have to also see whether you can adapt them in your industry. What are those? Leaders, leaders, leaders. It starts with the top management, with the leaders. All of you are training yourself to be leaders. So you're demonstrating commitment to safety in all your decisions and behavior is critical for creating a culture of safety in the organizations. Decisions that you take should support or affect safety are systematic, rigorous, and thorough. Don't go by some rumors, gossips that you hear from your employees. You have to be on the ground. You have to walk the ground, learn out of it, go with data, evidence-driven. Trust and respect permeate the organization. When you do that, people believe in you, trust, and that permeates across the organization. Opportunities to learn about ways to ensure safety are sought out and implemented. Issues potentially impacting safety are promptly identified, fully evaluated and addressed. So everybody is involved in this activity, and a safety-conscious work environment is maintained where people feel free to raise safety concerns without intimidation, harassment, discrimination, or fear of retaliation. So these are the things that are characteristics of a safety culture in an organization. And the three essential components, fair and just culture. Second is the reporting culture, and the third is the learning culture. I want to quickly explain to you what these three cultures are. Just culture is when your staff are engaged. They are even rewarded for providing essential safety-related information. When we started with our journey in quality in 2007, let me tell you, we put up a system of sentinel event reporting, all that whatever NABH fancy terms they talk about was put in place. Nothing would get reported, nothing at all. And thereafter, today, if you look at it, every single day, after 13 years, 15 years, every single day, we get easily about 10 to 12 incidents getting reported. How has it happened? Because we encourage people to report. We never went into a punitive mode. We went into a root cause mode. We appreciated people who reported. So even if there's a loose wire today, I'll get a message immediately. Or somewhere, anonymous reporting, whatever it is. People take safety very, very seriously. So what we need to do is to understand that put a system in place, a just culture, so that people are not punished for the mistakes that they are doing. But very clear lines are to be drawn between human error and at-risk or reckless behavior. People try to hide behind that as well. Reporting culture is the most important thing. Staff report their errors and near misses, not just theirs, everybody. It's an issue that is, we have to address this. We have to get into the mode of reporting. A learning culture, that's the crux of this entire thing. The willingness and the competence to draw the right conclusions from safety information system, and the will to implement major reforms when need is indicated. So when our first audit started, this is something I have to mention to you. In 2009, we were standing outside the theatre and auditing all the case sheets of the patients who were wheeled into theatre. Only 57% of the patients, 100-odd patients who were wheeled into theatre, had consent for surgery. So this was presented in the medical board. And the immediate reaction of all the doctors is that this information may not be correct. We have formats, we write in our progress notes, we write in our initial assessment sheets. This may not be correct at all. So our report was not taken, and then the Deputy Medical Superintendent of Theatre was asked to do the audit. So the Deputy Medical Superintendent, a vascular surgeon, stood outside the theatre, and he started his audit. By 11 o'clock, I went to give him a coffee and said, "How are you doing?" He said, "Let's go back. It's only 48% of the patients who had consent for surgery." This time it was presented to the medical board, and the immediate reaction of all our heads of department. They said, "Dr. Saab, this is why we are saying our PG selection is so poor these days. They are all the time with their mobiles. They are not bothered. Our times were different. Our PGs are not cooperating." This was the response. And our director said only one thing: no patient will be wheeled inside theatre without consent for surgery, and the holding bay nurses are empowered to stop the case from being moved in. Believe me, even today, nobody can question the holding bay nurse. After that, it went on to 99% compliance. Today, we have more than 280 specific consent forms. What used to be 2 or 3 sentinel events in a year and no near miss at all reported, in the last 2 years, we have not had any sentinel event, touch wood, but every year we have more than 250 near misses reported. So when your incident reporting becomes better, when your systems are under control, your near misses will go up and your sentinel and adverse events will come down. So this is how the leader's involvement in quality safety is so crucial. That one decision changed the way we functioned in our theatres. So I just wanted to bring that as an example. And the most important thing is measuring the culture. You need to know where you stand, for which you need to measure the culture. If you can't measure it, you can't improve it at all. So how do I know whether my organization has a safety culture at all? There are far too many tools available. But what we are seeing today is the most adopted tool, which is Survey on Patient Safety Culture by AHRQ. Do a baseline assessment as leaders. Understand the culture in your organization. Every year, repeat this survey. Make sure that you are addressing issues. Of the 11 domains of this AHRQ, even today, our problem with reporting and also analyzing and reporting back the incidents to them has scored very low. So we are working on that. So that's what is most important. I want to end with this slide, where how do you promote a safe culture? You as leaders should know this well. Hold everyone, including the management, accountable for following safety policies to promote a very safe environment. Everybody is responsible. Establish the trust between your employees and management. Advocate an open door policy. That's the crucial aspect. Anybody who has a concern, may not be an incident, just a concern, has to just walk into the door of the CEO, the COO, or whoever it is and report. Hire employees who have eye for safety. That's crucial. We'll say that we don't get people and hire anybody and everybody. We have to be very, very cautious about this. Take safety incidents very seriously. Perform CAPA, communicate the actions taken. That's what is most important here. Train staff on risk identification. I need to know, as an anesthetist, what are the risks in the overall environment in the hospital, not just in anesthesia setting. Train them. Provide staff with risk management and safety measures. Engage with the staff to build a culture of safety. Lead by example. So that's crucial, where you as leaders stand in the front and lead by example. Please understand, all this we are doing is for the patient. We are not patients today, but at one point we may also become patients. So we get into a hospital which has no culture of safety, we are gone. So we need to understand whatever we are talking about, whatever we are doing as administrators, doctors, nurses, technologists, it's all about that one single individual that we treat. He may be the sole breadwinner of the family. He is the father of a very small kid, son of an old father, husband of a very young lady. And he is now your responsibility to treat him, send him safe to his loved ones. Imagine your own brother, sister, father, mother there. Take care of him like your brother. When you have that, the culture of safety will automatically come in. It is the love for your profession, as Dr. Avadis Donabedian said, it is the love for your profession, love for your God, and love for what you do that will help you develop this culture of safety, in my opinion. Thank you so much for this wonderful time given, and I really appreciate if you can take this message of culture of safety and building it in your organizations. Thank you for this opportunity. Can you come back?
Thank you so much, Dr. Lallu, for such a wonderful summary of building up culture of safety, and which entails each one of us right from top to bottom, and there are no shortcuts to it. That's what we come to. So we can fully relate to this part of the hospital culture of wherein safety is the most important. The first WHO principle comes is do no harm. So it starts from there, I guess. Now I would like to invite Dr. Renju Baby for discussing on medication error and patient safety. Please.
Thank you, ma'am. As respected chairperson, all experts or a ocean of administrators I could see. So warm good afternoon to one and all. So Dr. Lallu made my job very easy because madam has already covered almost all the crux of the topic which I am going to discuss. So madam told about the general patient safety as a whole. I'll be focusing on medication error and patient safety. So before starting, let me thank Dr. Jawahar, who gave me an opportunity to talk, because when I was having the responsibility of working as a nurse administrator, I was working, sir was my mentor in administration. So every day when I meet sir has every day has something to teach me, what I've realized is that his main focus is on quality. So whatever problem, like many errors when we discuss, when I go and present to Dr. Jawahar, sir always direct me towards finding the root cause and let us work to seal the wherever the loopholes, let us seal. So that was the encouragement sir has given me. So now I'll discuss about medication error and patient safety. So we know that quality is an overarching umbrella where the patient safety there is there, and patient safety actually Lallu ma'am discussed everything actually. So patient safety means prevention of harm to the patient, and our main aim is to reduce the risk, errors and harm that occurs to the patients during the provision of care. So I'll skip because madam has discussed all those things. So I'll focus on medication error. So medication error, as we all know, it is any preventable event. preventable event that may cause or lead to an inappropriate medication use or patient harm while the medication is in control of healthcare professional, patient or consumer. So we all know that error has been classified by various process, like whether it can be classified as per various process, like during the stage of prescribing, stages of transcribing, dispensing, administration, documenting and monitoring. Or the type of error can also be classified as wrong medication, wrong dose, wrong frequency, wrong administration, wrong route or wrong patient. So errors can be classified whether they occur from mistakes made when we plan action. So whether it can be classified as action-based error or slips or memory-based error or lapses. So as Madam was telling, errors are hardly getting reported. During my tenure of 2 years when I was working as a nurse administrator, hardly 6 to 7 medication error was reported. And out of that 7, maybe 3 or 4 were near misses. Like Madam was telling, people may report near miss, or otherwise it has to cause an adverse event or a sentinel event. But it is just a tip of iceberg. So huge amount is getting underreported. So it is the prevalence of prescribing error that has been published in literature. So the prevalence of prescribing error ranges from 2% to 94%, which is quite alarming. And inappropriate prescribing was most common type of error. And prevalence of monitoring error means incomplete therapeutic or safety laboratory test monitoring occurred in 73% of patients. This based on the systematic review findings. And the incidence of preventable adverse drug event is like 15 per 1,000 person years. And adverse drug reaction is from 7%, and the prevalence of preventable adverse drug event is 0.4%. And transcription error is found to be in peak with 41%, and prescription and administrative errors ranges from 40% and 14%. So these all are very this is not the actual level that we all know. And why the medication error occurs? Because of the interaction of several complex factors. The factors, it may be healthcare professional related factors, patient care factors, work environment related factors, medication related factors, and system related factors. So healthcare professional factors, so starting from clinician who is prescribing, then the pharmacist who is dispensing, and the nurse who is administering. So there are so many factors that make them vulnerable to make errors. So one is lack of therapeutic training. And suppose being a nurse, I'll say that if the nurses are not properly trained about the medication and why the patient requires the medication and what all the nurse should see when they provide the medication to the patient, and if they don't have adequate knowledge and experience, and if they don't know about the patient, and if there is a inadequate perception of risk that we normally see, people take it very lightly. So that may result in error. And when there is a shortage of staff or overworked or fatigued healthcare workers will make them prone for errors. The physical, mental health issues, the personal stress of employees, and the poor communication between the patient by the healthcare profession also can contribute to errors. And patient-related factors, the level of literacy. And level of literacy, I want to emphasize level of medication literacy also, the personality of the patient, language barriers, multiple comorbidity and polypharmacy also contributes to medication error. The work environment related factors, we all know that when the shift is too busy, when the workload is heavy, and when there is time pressure and multiple distraction and interruptions, and if there is no standard protocols or policies, and the resources are short, and when there is the environment itself, where there is inadequate physical work environment like lighting, temperature, ventilation. We all know that during COVID, those who have worked inside COVID unit, they used to tell me, after wearing goggles, we can't see what is written, or we can't see how to locate a cannula like that. So environment factors also contribute to errors. And medication related factors. So we know, after seeing these pictures, we know the similar looking drugs, or look-alike drugs, or sound-alike drugs, or similar packaging and multiple brand names that makes vulnerable for errors. And the system-related factors, because of the repeated ordering and processing, and lack of patient monitoring system, and lack of computer prescription system also leads to errors. So why there is underreporting? Because we are worried if I report whether I'll get some punitive action. So fear of punishment is one of the major reason. Because, and normally what happens when we report any error, normally clinician and nurses are often at the sharp end and the organization factors will become the blunt end. We don't know the exact figure because people don't report errors. So because of that, I have undertaken a study under the guidance of Dr. Jawahar. We wanted to know why people are not reporting. So we did a mixed method research. That finding I'll be discussing. So we did a research to explore the attitude, practice, facilitators and barriers of medication error among nurses. It was an explanatory sequential mixed method study. We as a part of ABQC Medication Safety Committee, we initiated the study. So phase 1 was a quantitative survey and phase 2 was a qualitative phase where we did focus group discussion of nurses, senior nurse, grade 2 nurses, senior nursing officer, ANS, residents and clinicians. And I'll be presenting the phase 1 study. So when we analyze the attitude of nurses, see 47% of nurses only had favorable attitude and 39 were neutral and 14 had unfavorable attitude. And when we asked what all errors you have identified during your clinical practice, so you see the type of errors, but very few errors actually gets reported to an administrator. So 82% said that there was no documentation of drug being administered. 51% said that they failed to document any allergy or interaction. So you can read. Because of time shortage, I'll not be discussing everything in detail. So when we inquired the error reporting practices, so have you reported medication error? So only 42.8% nurses said that they have reported. To whom they have reported? Majority they report to their immediate supervisor and then ward in charge, then duty resident doctor. But when it comes to higher authority, you can see very, very less people are comfortable in reporting errors to higher authority. And you see the number of errors they reported in the last 1 year. So majority of them are saying they have not reported any errors. And when we asked, have you intervened or prevented a near miss? You can see 62.6, they told that they have intervened or they have prevented a near miss. And when we asked, we had a medication error reporting, but we asked, are you aware? Surprisingly, 37.7% said that, only 62.9% said that they are not aware. So this is what, then this was really an eye-opener for us and we started training nurses about medication error reporting. So this is like both quantitative and qualitative aspect I'm presenting in a single slide. So you can see the barriers. So the major barrier, lack of awareness. They were telling lack of awareness about medication error reporting protocol. Because they don't know, that is why they didn't report. That was quite surprising for us. So we were expecting that it will be like fear of trauma, fear of punishment. These are the reasons they reported, why they don't report error. So when you see the qualitative aspect, when you see, they say that because it is not done earlier or it is not a regular practice in the institution, that is also prevent from reporting. If no one is doing, then why I should do? So, and they fear that if I report, it will cause, they'll punish me. I have to undergo series of interrogation, warning, suspension, and my APAR or my ACR will get spoiled. It will be a black mark for this in my service. So these all fears, and few fear legal action also. So that prevents people from reporting error. And these are the facilitators that encourage people to report error. They feel that if we have a cordial relationship and open communication, it will encourage errors. If there is a proper policy available, it will facilitate reporting. And if the errors are handled in a non-punitive way, and then computerized blame-free error reporting system also will facilitate error reporting. So we asked, what is your expectation? What do you expect from medication safety committee members? So they want them to be, they want the team should be training and empowering nurses and residents, appoint a designated medication safety nurse, and this team should be available and approachable for nurses. They should be creating awareness, and they should be training new joinees, and they should be conducting periodic training for nurses as well as residents. So these are the strategies, their expectation about from the medication safety committee team. So like coming back to the concept of medication error prevention, so while from this 9 patient safety categories, we can see what all aspects of how we can prevent medication error. So by adopting user-centered design, like for example, special lure locks for syringes and inbuilding lines and tubings. Avoid reliance on memory by standardizing process and type of equipment, and by ensuring adequate nurse-patient ratio. By distributing the workload, we can ensure we can reduce error. And avoid reliance on vigilance, because we can't expect that nurses or doctors will be all the time vigilant because they are overburdened. So limit the long shifts using automated equipments, and limit the frequent staff changes, and establish very interdisciplinary team training and collaboration can reduce occurrence of errors. And involve patients in their care, involve family in the decision making process, and provide medication literacy. Actually, yes, I'll just stop. So we have to, as nurse, I should say that as nurses, we really need to focus that we are literate, we are providing education about the medication to the patient, and anticipate for the unexpected. And we have to, if there is any error occurred, we have to have a strategy to mitigate adverse event or injuries. And we have to improve the access to accurate and timely information. So like Madam was telling, we have to shift from focusing on error to having a culture, a safety culture. So we have to shift from errors to safety practices. So this is how we can prevent the medication error by incorporating a closed loop medication management system. So everything is electronically linked, so that there is a minimum scope of having an error. So closed loop medication management system, here fully electronic medication management process which integrate automated and intelligent system to completely close the inpatient medication management and administration loop. So the literature shows that the closed loop medication management system reduces the number of reported adverse event. It reduces the reduction of observed adverse drug event. It reduces the errors causing harm, and it reduces the total time nurses spent in documenting medication administration per shift. And it also 70% reduction in the number of steps in medication administration. So as Madam was telling, we have to inculcate the safety culture. So it is very essential that we have to establish a medication safety culture also by having an effective teamwork and collaboration, institutionalizing a culture of safety by providing a patient-centered care and incorporating evidences. So this is what we, as a multidisciplinary medication committee team, we should be doing. So we should be sensitizing nurses and residents, conduct medication safety audit, conduct safety rounds, developing a safe reporting practice which is anonymous and blame-free. And the teams can give policy recommendation to administrators. We can appoint medication safety linked nurses, like we have infection control nurses, we can have medication safety nurses, and we can have medication safety linked nurses, one linked nurse from each unit, so that we can bring in or foster a safety culture in the institution. So as we all know, this year patient safety was focusing on medication safety. So medication without harm, that was a theme of World Patient Safety Day 2022. So like for 5 moments of hand hygiene, we have 5 moments of medication safety, which this we have to focus while educating the patient, because they have to take responsibility for their medication. And these are the 5 steps for ensuring medication safety, from prescription to documentation.
Thank you so much. Thank you, Dr. Baby. So we would like to invite at least 2 questions. We are running short of time, so 1 or 2 queries